Hi dear students. So today we are going to have a general discussion on the topic antibiotics. So let's get familiar with few of the words that we use in this session. So what is antibiotics? The Greek word anti means against and biotics means concerning life, and it refers to substances produced by microorganisms which selectively separate the growth of or kill other microorganisms at very low concentration. So what are chemotherapeutic agents? The use of drugs with selective toxicity against infections or viruses, bacteria, protozoa, fungi, and helminthes. And coming to the term antimicrobials. It refers to all the agents of natural, synthetic or semi-synthetic origin which at low concentrations kill or inhibit the growth of microorganisms but causes little or no host damage. Antimicrobials include both chemotherapeutic agent plus antibiotics. An antibiotic is a product produced by a microorganism or a similar substance produced wholly or partially by chemical synthesis, which in low concentration inhibit the growth of other microorganisms. An antibiotic is a selective poison and it has been chosen so that it will kill the desired bacteria but not the cells in your body. Each different type of antibiotic affects different bacteria in different ways. Let's check into the history of antibiotic. The use of substances with antimicrobial properties is known to have been common practice for at least 2000 years. Ancient Egyptians and ancient Greeks used specific molds and plant extract to treat infection. Also for centuries, preparations derived from living matter were applied to wounds to destroy infection. The fact that a microorganism is capable of destroying one of another species was not established until the later half of the 19th century when Pasteur noted the antagonistic effect of other bacteria on the anthrax organism and pointed out that this action might be put to therapeutic use. Microbiologists such as Louis Pasteur and Jules Pringles-Joubert observed antagonism between some bacteria and discussed the merit of controlling these interactions in medicine. Before the early period, some of the natural substances were used to treat several infections. For example, Kalmubra oil was used to treat leprosy, and the cinchona bark for fever, and the moldy curd was used by Chinese for treating the boils. The Chinese also used artemisia for malaria treatment, and mercury was used to treat syphilis. The Jordan people used red soil to treat skin infections. During 1890 to 1935, Ehrlich tried methylene blue, trypan red, etc. and he developed the arsenicals atoxyl for sleeping sickness, arsphenomen in 1906 and neo-arsphenomen in 1909 for syphilis, and he was the one who coined the term chemotherapy. In the modern era of chemotherapy, Demack in 1935 demonstrated the chemotherapeutic effect of protosyl sulfonamide dye in pyogenic infections. In 1928, Sir Alexander Fleming, a Scottish biologist, observed that Penicillium notatum, a common mold, had destroyed Staphylococcus bacteria in culture. Fleming was unable to purify the compound, and the penicillin was isolated in 1939 by Oxford chemist Howard Florey and Ernst Chain, and in 1940, first clinical trials of penicillin were performed. Whereas the mass production of penicillin started from 1945 and it was used during the World War II. Selman Waxman found that soil streptomyces make antibiotics, and he came up with the definition of antibiotic. In 1944, Selman Waxman and Albert Schatz, American microbiologist, isolated streptomycin and a number of other antibiotics from Streptomyces graecis. In 1947, Chloramphenicol was first used clinically to treat typhus. Burotsu discovered cephalosporins, and Benjamin and Degar isolated chlorotetracycle from a mud sample obtained from a river in Missouri. From 1960 onward, second-generation antibiotics like methicillin were discovered. Following this, semi-synthetic derivatives of older antibiotics with more desirable properties and different spectrum of activity were produced, for example, fluoroquinolones and oxazolidinones. And when you look at the history of antibiotics, you can see that between 1962 and 2000, no major classes of antibiotics were introduced. And when you look at the timeline of antibiotic resistance, you can see that the penicillin was found in 1943 and its resistance developed in 1947 with penicillin-resistant Staphylococcus aureus, and the methicillin in 1959 and the resistance developed in 1961 with MRSA, that methicillin-resistant Staphylococcus aureus. And then comes the vancomycin in 1958, and vancomycin resistant infections developed in 1987 with vancomycin resistant enterococci, and in 2002 vancomycin resistant Staphylococcus aureus emerged. There are different ways in which the antibiotics are classified, like based on the chemical nature, mechanism of action, type of organism against which they are active, spectrum of activity, and the type of action, and also finally based on the source of antibiotics. We can see a few examples of antibiotics which is classified based on their chemical structures. Sulfonamides and related drugs consist of sulfadiazine, dapsone, para-aminosalicylic acid, that is PAS. Diaminopyrimidines consist of trimethoprim, pyrimethamine. Quinolones consist of nalidixic acid, norfloxacin, ciprofloxacin. Beta-lactam ring antibiotics consist of penicillins, cephalosporins, monobactams. Tetracyclines consist of oxytetracycline and doxycycline. Nitrobenzene derivative, chloramphenicol. Aminoglycosides, streptomycin, gentamicin, neomycin. Macrolide antibiotics, erythromycin, clarithromycin, azithromycin. And there are few more examples like the lincosamide antibiotics like incomycin, clindamycin, polypeptide antibiotics, polymyxin B, bacitracin, glycopeptides like vancomycin, nitrofuran derivatives like nitrofurantoin, nicotinic acid derivatives, examples are isoniazid, pyrazinamide, polyene antibiotics like nystatin and amphotericin B. Azole derivatives include miconazole, clotrimazole, ketoconazole, fluconazole, and there are others like rifampicin, viomycin, ethambutol, thiacetazone, griseofulvin, and few examples based on the mechanism of action. For example, that inhibit cell wall synthesis include penicillins, cephalosporins, vancomycin, bacitracin. That cause leakage from cell membranes include polypeptides like polymyxins, bacitracin, polyenes like amphotericin B and nystatin. And which inhibit protein synthesis include tetracyclines, chloramphenicol, erythromycin, clindamycin. And that cause misreading of mRNA code and affect permeability. They are the aminoglycosides like streptomycin and gentamicin. And the ones which inhibit DNA gyrase are fluoroquinolones like ciprofloxacin. That interfere with DNA functions are rifampicin and metronidazole. And that interfere with DNA synthesis is acyclovir, siruvidin. And which interfere with intermediary metabolisms or that is involved in metabolic antagonisms are sulfonamides, sulfones, trimethoprim, pyrimethamine, ethambutol. For antibacterial treatment, drugs like penicillins, aminoglycosides, erythromycin are used, and for antifungal, rhizophlavin, amphotericin B, ketoconazole. Antiviral examples are acyclovir, amantadine, zidovudine, and for the antiprotozoal, chloroquine, pyrimethamine, metronidazole, and which are antihelminthic are the mebendazole, niclosamide, diethyl carbamazine. And the examples of narrow spectrum antibiotics are penicillin G, streptomycin, erythromycin, and which are broad spectrum are tetracyclines and chloramphenicol. And the bacteriostatic drugs include sulfonamides, tetracyclines, chloramphenicol, erythromycin, ethambutol, and the bactericidal ones include penicillin, aminoglycosides, polypeptides, rifampin, isoniazid, vancomycin, ciprofloxacin, metronidazole, cotrimoxazole. And based on the source of antibiotics, the fungal antibiotics include penicillin, rhizophlavin, cephalosporin, and the bacterial ones are polymyxin B, tyrothricin, colicitin, aztreonam, bacitracin, and the ones that is derived from actinomycetes include aminoglycosides, macrolides, tetracyclines, polyenes, chloramphenicol. Now let's see the principles of antimicrobial therapy. And the first step is a diagnosis that includes the identification of the site of infection, the responsible organism, and the sensitivity to the drug. And second step is to decide whether the chemotherapy is necessary or not. Acute infection require chemotherapy, whereas chronic infections may not. The chronic abscess respond poorly, although chemotherapy cover is essential if surgery is undertaken to avoid a flare-up of infection. Select the drug based on the specificity, pharmacokinetic factors, patient-related factors, whether they have any allergy or renal diseases. Next is the frequency and duration of drug administration. Inadequate dose may develop resistance and intermediate dose may not cure infection. So, optimized dose should be used for therapy. Usually, acute infection is treated for 5 to 10 days, but some of the bacterial infections are exception to this. For example, like typhoid fever, tuberculosis, endocarditis. They are even continued after the clinical cure in order to avoid relapse. Test for cure. It's needed because after therapy, symptoms and signs may disappear before the pathogen is eradicated, and prophylactic chemotherapy is needed to avoid surgical site infections. Choice of an antimicrobial agents depend upon the patient-related factors, drug factors, and the organism-related considerations. First, let's see the patient-related factors. Patient age is an important factor. Chloramphenicol produces gray baby syndrome in newborn, and tetracyclines deposed in teeth and bone below the age of 6 years. And also, if the patients have any renal and hepatic dysfunctions, when we use drugs like aminoglycoside, vancomycin, it will result in renal failure, and erythromycin tetracycline result in liver failure. Also, the history of known antimicrobial agents allergy should be obtained. That is, if the person is having allergy to some of the drugs. For example, syphilis patient who is allergic to penicillin can use tetracycline as a drug of choice. Fluoroquinolones sometimes cause erythema in some patients. And the other factor is the impaired host defense, that is, if the person is immunocompromised due to any other diseases. And the drug factors include whether the patient is pregnant. During pregnancy, all antimicrobial agents should be avoided, even though many cephalosporins and erythromycins are safe. And the next one is the genetic factors. Primaquine, sulfonamide, fluoroquinolones are likely to produce hemolysis in glucose 6-phosphate dehydrogenase deficient patients. And the other drug factors include the spectrum of activity, type of activity, sensitivity of the organism, relative toxicity, pharmacokinetic profile, route of administration, and cost. And the next one is the organism-related considerations. A clinical diagnosis should be first made and the choice of the antimicrobial agents are selected. Clinical diagnosis itself direct choice of the antimicrobial agent. Choice to be based on bacteriological examination, such as the bacteriological sensitivity testing. Problems with antimicrobial agents include toxicity, hypersensitivity reaction, drug resistance, drug tolerance, and superinfection. Toxicity include local irritancy, usually at the site of administration, and there is also gastric irritation, pain and abscess formation at the site of intramuscular injection. There can also be thrombophlebitis of injected vein, and the systemic toxicity includes dose-related organ damage. High therapeutic index agents may not damage host cells, for example penicillin and erythromycin, and the agent which have low therapeutic index exhibit more toxicity. Very low therapeutic index drug is used when no suitable alternative antimicrobial agents are available. For example, vancomycin results in hearing loss, kidney damage, Redman syndrome. Polymyxin B result in neurological and renal toxicity. Next problem associated with antimicrobial agent is a hypersensitivity reaction. All antimicrobial agents are capable to cause hypersensitivity reaction, and this reaction are unpredictable and unrelated to dose. For example, penicillin induces anaphylactic shock. Next one is a drug tolerance. It is a loss of affinity of target biomolecule of the microorganism with particular antimicrobial agent. For example, penicillin resistance to pneumococcal strain. It results due to alteration of penicillin binding protein. So next one is a superinfection. It is an infection occurring in a patient having a pre-existing infection. Development of superinfection is associated with the use of broad or extended spectrum of antibiotics such as tetracyclines, chloramphenicol, ampicillin, and newer cephalosporins. Superinfections are more common when host defense is compromised. Superinfections are generally most difficult to treat. For example, bacterial superinfection in viral respiratory disease, infection of a chronic hepatitis B carrier with hepatitis D virus. Superinfections can be minimized by using narrow spectrum antimicrobial agents whenever possible and avoid using antimicrobials to treat self-limiting or untreatable infection. Also avoid prolonged antimicrobial therapy. Another major problem associated with the antimicrobial agent is the resistance development. It is the unresponsiveness of a microorganism to an antimicrobial agent and is similar to the phenomenon of drug tolerance. It's broadly divided into natural resistance and acquired resistance. Natural resistance. Some microbes have resistance to certain antimicrobial agents. For example, gram-negative bacilli is not affected by penicillin G, and Mycobacterium tuberculosis is insensitive to tetracyclines. Acquired resistance. It is the development of resistance by an organism which was sensitive before due to the use of antimicrobial agent over a period of time. For example, Staphylococci tubercle bacilli develop resistance to penicillin because of its use for more than 50 years, and gonococci quickly develop resistance to sulfonamides.